So when I was in the hospital getting ready to have my oldest daughter, the doctor walked in, and the first thing he did was to sit down on the edge of my bed, which I thought was really stupid of him because I was in labor, and he didn't care that I was in labor and that it hurt. And after he sat down on my bed, he started talking to my then husband about what was going to happen next, not in terms of what was going to happen with my husband being in the delivery room and trying to explain it that way, but telling my husband, well, this is what I'm going to do, and this is how we're going to proceed with all of this, and did not even look at me to tell me this is what we're going to be doing and this is how your body is going to be feeling. But it was important for him that my husband understood all of that.
You know, you talking about that reminds me about the process of me getting pregnant. And in Oklahoma, where we were living at the time, Oklahoma laws and statutes were such that doctors would not help with fertility treatments for single women. And that was bias all based on it's not okay to be a single mother. It's not okay to do a family that's non-traditional. And we actually had to travel over 100 miles to find a physician who would help with the fertility process with a single woman, and just the extra resources that required and the extra time and commitment. It was just ridiculous that, that there was that bias.
Mm-hmm. And it isn't always from male doctors. When my sister was diagnosed with breast cancer, the doctor had a year earlier than that palpated a lump in her breast and said to her, well, we're just going to keep an eye on it for the next year because you have dense breast tissue. Within a year, she was diagnosed with stage 4 breast cancer.
In the ER.
In the ER, because she wasn't taken seriously when she brought this concern to her primary care physician. And her primary care physician was a woman. So it isn't always, male doctors either that have the bias that, well, you really don't know what your health care is. We know better than you do.
And then there's the whole institution of healthcare. And when I was, it feels like a million years ago, doing my chaplaincy residency in seminary, I was an on-call chaplain at the hospital in St. Joseph's, Missouri. And because Medicaid is determined by each state, it's federal dollars, but each state determines how they spend it. In that point, Missouri didn't choose to spend it on the healthcare needs of families. They would care for children, but not for families. And so we had a patient come in with her 16-year-old daughter, and the patient had to play Russian roulette with her asthma. And she didn't have access to primary care. The only health care she had access to was emergency room access, and then all the bills that came with it. And so she put off going to the hospital as much as she could. But when she got really bad in her asthma, she'd show up at the hospital, and people, we would get things settled down. Well, this time, she shows up at the hospital with her 16-year-old child, and she dies because she was in a cycle of healthcare that didn't take her seriously, that forced her to not be able to access care when she needed it, to prevent these kinds of situations. And she died because of our healthcare system. She didn't have to die. And her 16-year-old daughter was at the hospital for a good 12 hours waiting for somebody in the family to come and be with her after her mother died.
I had experiences with women on hospice who were diagnosed with end-stage cardiac disease, who had heart attacks. In fact, one just recently, who had a heart attack that damaged more than half her heart. But she was initially diagnosed with acid reflux and indigestion, and by the time they figured out that she really was having pain and she really was in trouble, half of her heart was dead.
And now she's on hospice.
And now she's on hospice.